Good morning, everyone. Tuesday, March 21st, 2023. It's a little after 9 a.m. at the State Capitol Conference Room 329. First bill on the agenda is Senate Bill 1351. Could I get the judiciary, please? 1351. Judiciary. Provided comments. Next up, Office of the Governor. Not present. Strong support. Executive. Oh, I'm sorry. Senate Bill 1351. This is relating to the early childhood mental health. Oh, okay. Come on up. I had Blake Oshiro. I don't see Blake here. But no. If you're representing the governor's office.
Okay. Tia Hartsock, Executive Director, Office of Wellness and Resilience in the Office of the Governor.
Right. People are interchangeable like this.
Yes.
We're good, so it's good that you're representing.
In strong support of 1351, available for comments. Yes.
Thank you. We know this is a priority bill for the governor, and so we got that. Thank you very much. Executive Office on Early Learning.
Aloha Chair, Vice Chair, members of the committee. I'm Jordana Ferrer with the Executive Office on Early Learning. We stand on our written testimony in support of this measure. Thank you.
Thank you very much. Department of Human Services.
Morning, Chair, Vice Chair, members of the committee. Kathy Betts, Director for the Department of Human Services. Will stand on our written testimony in strong support of this admin measure. Thank you.
Thank you, Director.
Thank you.
Disability and Communication Access Board. Provided testimony in support, Epic Ohana. Provided testimony in support, Parents and Children Together, PAC. Provided testimony in support, Early Childhood Action Strategy. Hi.
Good morning. This is Doug Emig speaking on behalf of Early Childhood Action Strategy. We stand in support of our written testimony. Thank you.
Okay, thank you. Thank you very much. Next, we have Family Hui Hawaii support, provided testimony support, Hawaii Association for Infant Mental Health. Testimony in support, Hawaii Children's Action Network speaks. Testimony in support, Commit to Keiki. Hi.
Hi. Aloha, Chairman Zano and Chair Albalotti. We stand on our written testimony, and we encourage all of you to be interrupters. Interrupters of a growing mental health crisis, particularly in our youth. Please move upstream, invest in our youngest keiki, and prevent kids from harming themselves, harming others, withdrawing, and falling into substance abuse. This bill fills a really critical gap in our current system of supports. We can prevent mental illness in most cases, but we really need to invest early. So mahalo for your support.
Thank you. Thank you very much. Hawaii Community Foundation provided testimony in support. Family Support Hawaii, testimony in support. And I've got 10 individuals, 9 all in support, 1 in opposition. So if there's anyone here or on Zoom that would like to provide testimony, please come on up and let us know. Yes, Lauren, yes, from Department of Health.
Good morning.
Oh, I apologize. I got your late testimony.
Yeah, it is late.
It's on me. I forgot.
No.
Great to see you, Mr. Kim.
Thank you. Good morning.
Good morning.
Lauren Kim, Planning and Policy Officer for DOH. Very sorry for the late testimony. This is an extremely critical bill, but we were lining up stakeholders to make sure that our amendments, our friendly amendments, were universally supported, and I believe we achieved that, and that took us to the deadline to submit testimony. We're requesting 2 friendly amendments, the first of which is to replace the word program with pilot project. As Rep. Kobayashi pointed out prior to crossover, there is no budget corollary, so it's premature to actually amend statute, especially Chapter 321, our statute. So a pilot project is more appropriate in session law. We will evaluate the program, and if it does what we hope it does, we will come back with data, legitimate write-up, and a base budget request, and amendments, several sections are apart to Chapter 321 or the appropriate statute. So the first is replace program with pilot project. The second is we want to make sure that all the actors in in or adjacent to the space of 0 to 3, 0 to 5 are at the table, so there's no duplication of work and dilution of resources. So we just like to put in that the Department of Health shall collaborate or coordinate with the Executive Office on Early Learning that has a statutory responsibility for the 0 to 3 age group, and other partners as they're willing to step up, like the Office of Wellness and Resilience. They all need to be in a room. It's great to have it as a legal standard in this case, so that we're formally communicating with each other and making sure this is a success. Thank you very much, and let me know if there's any questions.
Right. Thank you, Lauren. These are reasonable amendments, so thank you very much. Okay, that's it. Anyone else wishing to testify on Senate Bill 1351? Please come
Hi,
on up.
me.
Hi.
Hi, I'm Leslie Cabaya, testifying in strong support of SB 1351. Early childhood experience and interactions can have significant impacts on our keikis' overall mental health. By providing our keikis with the necessary support and resources, we can help set them on a path towards positive outcomes. Thank you.
Thank you for your testimony. Anyone else wishing to testify on Senate Bill 1351, Senate Draft 2?
I would like to testify.
Sure. If you could state your name, please.
Yes, my name is Taylor, and good morning to the Chair, Vice Chair, and esteemed members of the Senate Committee on Health and Human Services. I'm getting my MSW specializing in behavioral mental health, and I've had many years of experience with the youth of Hawaii at all stages of development. And I would just like to state that I stand by my testimony in support of Bill SB 1351. Mahalo nui for the opportunity to testify. Aloha.
Thank you, Taylor. And we do have your written testimony. Thank you. Thank you. Anyone else wishing to testify? Okay, if not, members, questions on Senate Bill 1351? Chair Belatti.
Department of Health. What conversations have occurred between executive representatives and the Child and Mental Health Division? Child and Adolescent.
Between DOH CAMD and some of the other stakeholders, they're definitely aware and supportive of the concept. Their eligibility usually begins at about 5 years old, so there is a PUCA. We have been early on, less so these days now that we've established, I think, a better policy trajectory, but they are in consultation. We are in consultation with them. We share testimony to make sure that it's okay with them. And we've shared some of the models that have been proposed for consultants, and they do not seem to have a problem with that. The other Department of Health program that's involved is Family Health Services Division, and they have been real thought leaders in this area for quite a while. At least 3 DOH programs, my office, Family Health Services Division, and Child Adolescent Mental Health Division have been at the table discussing the future of this pilot.
What are the consultant models that you just referenced? What are those?
The consultant models are to provide training and technical assistance to child care providers, people in the early intervention and education space on signs of looking for early indications that there may be some undiagnosed or untreated conditions. Does an infant meet your gaze? Is there coordination there? So that is the most immediate PUCA that we see. There needs to be a larger, more comprehensive system for sure, but we think that this is a reasonable place to start. And technical assistance, bringing in a handful of consultants, I think 3 or 4 the first year and maybe an additional 5 to 6 the next, lets us hit the ground running while we continue to plan on a larger, more comprehensive system and program.
So say that again, training for what kind of providers?
Consultants.
Consultants for training for what kind of providers?
Child care providers, folks who would be in the space or adjacent to a child who's between 0 and 3 years old. We can get you more detail in writing if you wish.
Can you please provide us, since it sounds like you folks might already be looking at certain kinds of consultants and maybe even specific consultants?
Yes.
So yes, please
We'll
provide
get you some
that.
information as soon as possible, by the end of today.
Okay, thank you.
Mm-hmm.
Thank you, Chair.
Thank you, Chair. Is Judiciary here? I think we got comments from them, but is there anyone from Judiciary? Okay, I apologize, Vice Chair. Judiciary is not here. Any further questions? Yes, Representative Kobayashi.
For DOH, I'm concerned about the term services for children up to age up to 5 years of age. We have all these so-called cutoffs. We see that a lot in early education, you know. And let's see, in DOH, you have the Early Intervention Coordinating Council. And I'm not sure that you want to box yourself in just to age 5. Maybe a friendly amendment would be services for children. Let's see, services for children up to and including 5 years of age, which might give you a little flexibility to go for children in general.
I definitely appreciate the sentiment. I think a lot of the times our government programs pick, public policy is about drawing a bright line through a gray area, and we get stuck in these artificial, usually budgetarily constraints for age. I think we're open to that amendment. There are systems of care that begin at 5 and maybe a little younger, especially with the emphasis on pre-K. So that's part of the reason why we wanted to make sure that we have other actors at the table who are in the 0 to 3, 0 to 5 space. 0 to 5 may provide the pilot program with more options. I don't know in the beginning if we want more options. I think maybe we can take a look at the originally proposed 0 to 3 and I'll report to the legislature, or maybe a part of the money we can have a cohort that's 0 to 5 and 0 to 3 or whatever it is. So I think there's some flexibility in the way we can approach this. The extent to which it's in language, we defer to this committee to make those recommendations. Everybody acknowledges that this is a puka that needs to be filled. And again, the 0 to 3 was the most obvious. But I think the stakeholders would be open to 0 to 5 as long as we have some flexibility in how we create the cohorts.
Thank you.
So there would be no opposition.
Thank you very much. We've got a question from Chair Bellotti.
Follow up. It's not that, I don't think the concern is that there's flexibility, it's that there's coordination. Because if we do
Yes.
0 to 3, then you guys leave a gap from 4 to 5, and that's precisely creating another gap.
Good
So it's
point.
not about flexibility, it's about coordinating across the different programs that are in Department of Health. Do you understand that?
No, I completely understand that it's not just the Department of Health. That's why we wanted Executive Office on Early Learning, which is DOE, Office of Wellness and Resilience, which is Office of the Governor. Potentially one of these days it'll go into a different agency. There's a proposal on the table. And this is all about all hands on deck plugging the gaps. So then if that is the explicit concern, then we would definitely welcome that amendment and take it to heart and run with it.
For another question.
I have another question. in
Yes,
a
of
different
course, go
area.
ahead. Go.
In a different area?
Okay, I'll ask. I have a question. I'm sorry, anyone else? The question, okay. We'll come back to Chair Bellotti. Lauren, since you're already up here, I just want to make sure that this, I know you're working with some groups that focus on 0 to 3, but at the end of the day, this bill covers 0 to 5, is that correct?
Yes, I believe so, and we're fine with that. The original program intent was 0 to 3. Those have been some of the discussions, but again, the bill moving forward with 0 to 5 is completely acceptable to us.
Right, and hopefully, I mean, Representative Kobayashi, does that address your concern about maybe we should have it up to children up to 5 years of age? Bert? Oh,
Well, I was thinking of the wording up to and including 5 years of age.
Got it.
So,
So once they hit 5, it's not a hard.
so 5 is not a
Hard
good
stop.
line, a bright line through
Yeah,
a
so I
gray
think I got our
area.
committee members, which I totally depend upon, saying up to and including 5 years of age. It's a friendly amendment, don't
Yes.
you think?
Yes.
Thank you. No, I think our committee is cool with that, and if you're okay, I think that's going to be added as.
We
as the
definitely do
friendly-
not want to create more gaps or sub-gaps, so
Okay.
thank you for that
Okay. And I understand what
observation,
you're
Chair
saying,
Bellotti.
because specialty court is 0 to 3.
Right.
And they do a great job with reducing possible ACEs to our youngsters, our infants. So we agree, and if you're fine with that friendly amendment, I think that's where our committee's going to roll with.
I think in previous testimony, the department wrote that in our last published strategic plan, which is pre-pandemic. Our goal was create and improve systems of care and resilience for children 0 to 5. So that's consistent with what we said before. 90% of a child's brain develops between the ages of 0 and 5. So this is consistent with some of the strategic direction that a previous director has set us on. And we're
Okay.
happy to continue on that path and make adjustments along the way with stakeholders.
And thank you, Mr. Kim. Thank you for working with our committee.
I appreciate your openness to our amendments.
Okay, and I think Chair Bellotti
Actually,
had...
I'll pass on my question. It'll come up in another
Are you happy
context.
with that?
Yes.
Thank you very
Thank you,
much,
Chairs.
Mr. Kim. Thanks, Chair. Okay, members, if there's no further questions, we're going to take up the next bill on the agenda. It's going to be Senate Bill 404, Senate Draft 2. First up, Department of Human Services.
Good morning, committee members, chairs. Judy Moore Peterson. On behalf of the Department of Human Services, we stand on our written testimony in support. Thank you so much.
Thank you
Available for
very
any
much,
questions.
Dr. Judy Moore Peterson. Okay, next up, Hawaii Primary Care Association. Provided testimony in support, Hawaii Pacific Health. Thank you very much. Next up, Queens Health System.
Queens stands in strong support, Chair. Thanks so much.
Thank you, appreciate it. Thank you very much. Healthcare Association of Hawaii.
Hilton Rizzo, representing Healthcare Association of Hawaii, stand in strong support. Thank you.
Thank you very much. And we've got two individuals providing testimony in support. Anyone wishing to testify on Senate Bill 404, Senate Draft 2, please come on up. Jonathan?
Hi, Chair.
I don't think I got your testimony, my
You
friend.
didn't, Chair, so I apologize. Jonathan Ching for Kaiser Permanente. I submitted just probably 15 minutes ago. I'm so sorry, there was a fluke with submission. But I want to stand on the record that Kaiser Permanente is in strong support of SB 404.
Strong
My apologies.
support. No problem. Thank you, Jonathan. Okay, anyone else wishing to testify on Senate Bill 404? Okay, if not, members, are there any questions? Questions? No questions? Okay, thank you. Yes, Representative Kobayashi.
In expanding the definition of private hospitals, are we leaving anyone out? Or does this now cover everybody? I mean, who's left out under this definition, under the current definition? And who would be included with the expanded definition?
The couple of hospitals that are not included in the hospital sustainability program would be the HHSC-related hospitals. They're not included as their public hospitals. And then I believe Shriners is also not included, and I don't know the other ones. But there's those are the primary ones that are excluded entirely. And then the definition also allows us to distinguish amongst the private hospitals. So there's some that, I believe it was Kahimahala, the rehab hospital, that are not full acute, that don't provide the full realm of acute care hospitals. And this definition allows us to distinguish amongst them.
So Kahimahala would be included?
They're included, but we're allowed to tax them. I believe it's on the outpatient side. I'm looking for my help over here. Yeah, on the outpatient side, I don't believe that we include the inpatient side.
And with this expanded definition, are all hospitals in Hawaii covered now?
With exceptions, yes. Everybody's defined. Not everybody participates. So none of the HHSC hospitals participate. So when you asked, are all hospitals covered? They're not included in the hospital sustainability, but they are included in the definition by being excluded.
Thank you.
Okay, and Chair Bellotti.
Is Maui Health Systems included?
They're included.
They're included. So HHSC, they're not considered an HHSC hospital.
That is correct.
Okay, thank you.
Thank you, Chair. Any further questions, members? Okay, Sina, thank you, Doctor. Okay, members, thank you very much. We're going to move on to the next bill on the agenda. Senate Bill 397, Senate Draft 2, University of Hawaii. UH? Okay, they provided testimony in support. Department of Human Services.
Morning, chairs. We stand on written testimony and support. I do want to note that we do have also a budget request included in the governor's budget. So just calling that out as well, besides the bill. Thank you.
Thank you, Doctor. Okay, next up, AARP Hawaii. Provided testimony in support. Hawaii State Center for Nursing. Provided testimony in support. Aloha Care. Testimony in support. Oh, I'm sorry, Paula. Yeah, thank you. Hawaii Substance Abuse Coalition. Testimony in support. Hawaii Pacific Health. Thank you very much. Hawaii Pacific Health Institute. Testimony in support. Kauai Community Health Alliance. Testimony in support. Hawaii Provider Shortage Crisis Task Force. Testimony in support. Kaiser Permanente. Thank you very much. Central Oahu Speech. Testimony in support. HSHA. Testimony in support. HMSA. Thank you very much. Hawaii Association of Professional Nurses. Testimony in support. The Queen's Health Systems.
Chair will stand in strong support.
Thank you. Thanks, JC. Hawaii Medical Association. Testimony in support. Hawaii Association of Health Plans. Testimony in support. Okay, this is just what I got as organizations. Three Little Ducks. Three Little Ducks, testimony in support. Judy Moore Peterson knows sometimes people put some interesting things on a testifiers list. Got to be extra careful. So, Hawaii Independent Physicians Association, testimony in support. And I've got 20 individuals providing testimony, 18 in support, 2 with comments. So if there's anyone wishing to testify on this measure, either here on Zoom, Hilton, come on up.
Thank you. I believe we did submit testimony that we can resubmit if you have not received it. Thank you
I'm
very
wondering
much.
if the HSHA was actually H. It doesn't have your name on it though, but I apologize. I didn't see it here, but yeah, I'm sure if we don't have your testimony, we can get it from you.
We'll get it. Thank you very much for
Thank
the opportunity to testify. This measure would increase the Medicaid professional fee schedule to be equivalent of 100% of the rates paid by Medicare. This is a critical issue for this state. The low Medicaid, current low Medicaid reimbursement fee schedule for professions, for healthcare professionals is a barrier to access, unfortunately, which impacts the health equity of these individuals. So we're very, very supportive of this measure. It's not going to solve all the access issues we have in this state, but it is a critical foundational step for us to advance health equality in the state of Hawaii. Thank you for the opportunity to testify.
Thank you, Hilton. Thank you. Anyone else wishing to testify on this measure? If not, members, questions? Yes, Representative Kobayashi.
For, I guess, DHS, Hawaii Association Professional Nurses has what I think might be a friendly amendment and suggests deleting the words "up to" so that it would read that the increased Medicaid payments would be at 100% of current Medicare rates. Is that a friendly amendment or counter to what you want to do? The words "up to 100% or at 100%?
I think it would be fine to include it, to include the at as opposed to the up to. I'm trying to recall why we might have thought about that language, and I can't think of a reason of why that would be a challenge. So we would look at that as a friendly amendment.
would there be any instance where you would go beyond 100%?
It's possible for us to go above 100%. We don't, I'm trying to think of, again, examples where we go above 100% of Medicare, at least in the medical professionals. I can't think of any. We have many rates that Medicare doesn't provide anything. You know, there's no rate. There are some areas regarding children's services when it comes to early periodic screening, diagnosis, and treatment, where the codes might be the same, where we may go above Medicare. But for this particular bill, it's for the appropriation, and I believe that using this particular language of at Medicare for this appropriation would be appropriate. We could do that.
But there could be an instance in the future where you might want to go above 100%?
Correct.
So
for some services.
Wouldn't it be
easier
easier if we just write in language that would allow you to go up to and beyond 100%?
Let me look up the language here. The bill. Sorry. Okay, so the bill itself is the appropriation, and it is the bill provides the appropriation and directs us to take our Medicaid fee schedule, up to 100% of the Medicaid Medicare rates. I don't believe that the language is written in a way that would prevent us from going above that should we need to, or should we want to, or should we be directed to. So I believe that given the fact that the way that the language is written in section, I'm looking at section 2, we would be able to take it, up to and above, but the at Medicare rates for this particular appropriation, we should be able to accomplish that with that change.
Thank you.
Thank you, Doctor. Any further questions? Okay, I had a question for you, Hilton. If you can come on up. We discussed this bill even before the session started, and my understanding is that, I'm just saying it in general, many times we lose doctors, nurses, social workers because of the low Medicaid reimbursement rate. Currently, it stands at 60% of Medicare. Is that correct?
60% of Medicare, except for primary care physicians for what we call their E&M codes, which are evaluation management codes. They are currently paid by the state at 100% of Medicare just for the E&M codes for primary care physicians. All other services are pegged at that approximately 60% of Medicare.
Right. Hilton, the genesis of this bill was to try to equate Medicaid to Medicare reimbursement rate, which would be significantly higher for doctors, nurses, social workers, healthcare workers taking Medicaid clients. Is that correct?
That is correct. Any dollars allocated to this only apply to healthcare professionals who actually provide services to Medicaid. If you don't take any Medicaid, you're not getting any benefit. So it only benefits those providers who do take care of Medicaid recipients. And we have, as we all know, we have a large number of Medicaid recipients in the state. There are barriers to access because they can't get sufficient access. This would have a material impact, as you've heard from the testimony of many healthcare providers in the state.
Right. Many professional healthcare providers do not take Medicaid clients simply because reimbursement rate is too low.
The economics, that is correct. The economics, unfortunately, They are dealing with all the costs. They've got to pay staff, they've got to pay rent, they've got to take care of their office, and many physicians have to manage how many Medicaid patients they take simply to keep their office afloat because of that low reimbursement. So if you were to approve, the legislature were to approve this funding, this would have a material impact on a couple of things. Obviously on the ability of our Medicaid recipients to get much more ready access because many more physicians will be able to see them, and also will help us in terms of physician recruitment and retention, because it puts more money into the pool that we are paying not only for physicians but psychiatrists, any other healthcare professional who is reimbursed under this fee schedule. So it's not just physicians.
Thank you. And Hilton, last question, but we're trying to bring it up, Medicaid reimbursement to 100% of Medicare. We're not asking for 110% or 120. The way the bill is written, it's just, at this point, the effort is to get 100% Medicare reimbursement for Medicaid services by professionals.
Yeah, that is correct. As the as Judy Moore-Peterson, MedQuest Administrator, is that your title? MedQuest Administrator testified, there are some services that may be paid a little above Medicare, that are very high need services, for example. Some exceptions are made. But in general, this is designed to ensure that what we've already done for primary care physicians for their evaluation and management codes, we want to do this for all the other services that primary care physicians provide, and any services provided by any other clinical professional who is providing services to Medicaid. So again, huge impact. It would bring $30 million in state funds with a federal match. Approximately $70 million a year would be put into the professional fee schedule.
Right, I saw the numbers. $30 million in state general funds will draw down approximately $43 million
Somewhere in that.
federal Medicaid funds.
That is correct.
For $73 million for our professionals caring for Medicaid patients.
And this will help specifically on the neighbor islands as well. We have our most acute shortages, and where we have a higher proportion, especially on the Big Island, for example, but on areas of Oahu as well, we have high proportions of Medicaid recipients. This will help desperately in terms of or help critically in terms of those shortage areas for, for doctors and other, behavioral health therapists, psychologists, anyone else who's covered under that fee schedule.
Directly related to the concerns that we had years ago also, and still today, is the exodus of doctors and healthcare professionals going to the mainland because Medicaid reimbursement is too low.
That is correct, yes.
Okay, well thank you, Hilton. Any further questions, members? If not, thank you very much.
Okay, thank you.
Appreciate it. Okay, thank you, members. We're going to move on to the next bill on the agenda. That would be Senate Bill 1473, Senate Draft 2, State Council on Developmental Disabilities. Provided testimony in support, Department of Health.
Chairs,
Good morning.
Committee. Ryan Lee, Medical Director, Department of Health Developmental Disabilities Division. We stand on our comments, on our testimony offering comment.
Okay, thank you very much. Next up, Department of Human Services.
Good morning. Judy
Good
Moore-Peterson, on behalf of the Department of Human Services, we stand on a written testimony offering comments. Thank you so much.
Thank you very much. Next up, we've got Disability and Communication Access Board. Provided testimony in support, Hawaii Disability Rights Center. Provided testimony in support, Hawaii Fetal Alcohol Spectrum Disorder, FASD Action Group. Provided testimony in support, Hawaii FASD Action Group, Darlene Chen Scoville.
Good morning, chairs,
Good
vice
morning.
chairs, and members of the committee. I am here to strongly support this bill and also to make a friendly amendment or an addition to include fetal alcohol spectrum disorder in this group, because as you know, they do not have any services, and they're falling to, not into the crack, but they fell into the cliff and they were forgotten. So I'm please begging you to include FASD in this bill. Thank you.
Thank you, Ms. Chen Scoville. Thank you. Next up, I've got the Hawaii Association for Behavioral Analysts. Next
Thank
up,
you, Chair, Vice
Hi,
Chairs,
sorry.
and members of the committee. Kristen Copa-Bird on behalf of the Hawaii Association for Behavior Analysis. We stand in support with our written testimony, but would like to call attention for the departments as well as the committees. New Mexico has already passed a state plan amendment. It was approved January 25th of this year and has specific language for prohibiting age and dollar limits on services under the Medicaid plan, and provides coordination between waiver services and medically necessary ABA services. Thank you.
Thank you very much. Do I have any other testifiers for HABA, H-A-B-A? If not, they did provide testimony in support. I've got B-A-Y-A-D-A. Bayada. Pamela Wood provided testimony in support. Council of Autism Service Providers, testimony in support. And I've got 37 individuals, all in support with one providing comments. Linda, did you want to come on up? Good morning.
Good morning, Chair and Vice Chair and the members of the committee. I'm Linda Elento, and I'm a parent, and I'm happy to be here to support this particular bill. I did provide several examples of why I believe this bill needs to be passed. We certainly have a big need for it, and I'll just point out a couple of things. A Medicaid waiver program offers what the departments call ABA services per se. That was in last year's testimony for about another resolution regarding the same subject, and it's not working. My son also qualifies for DDD services, and we've been waiting for over a year, and that service has not been provided for him, even though he qualifies and needs it, because when he turned 21 last year, Medicaid stopped, even though he still needed the service. So just to give you a distinction with the Medicaid waiver program, in another testimony that the agencies, either Department of Health or Department of Human Services, had mentioned that the home and community-based services, like the waiver, provides assistance to individuals, whereas ABA actually teaches and gives behavior training to these individuals so that they can be independent. And that's something that we seek when our young adults turn 21. So I'd appreciate your looking at the other matters here that I've listed. I know time's of essence here, but then you've got my testimony, and I really appreciate your consideration.
Thank you, Linda. And we do have your testimony. Thank you very much. Okay, anyone else wishing to testify on Senate Bill 1473, Senate Draft 2? Okay, if not, members, questions?
I have questions.
Yes, Chair Bellotti.
I just have one question for Ms. Alento, but then I'm going to have some questions for Dr. Moore-Peterson and then Dr.
Yes.
Lee. Ms. Alento, and I really appreciate that you've advocated so long at the legislature on all of these important issues. Question is your son still under the care and services of the Department of Education?
He, because of the COVID impact, they've offered the behavior support services outside of campus since end of December. He was qualified. However, they've not been able to provide that support. There's not been the people.
Is it your understanding that because he has coverage through the Department of Education that will go through the age of 23 or 26?
No, with the Department of Education, the IEPs end at the age 22. So even last year, but prior the last year of school, he did not have Medicaid coverage.
Okay, but DOE does have jurisdiction until the age of 22.
This
Oversight.
Well, the needs are different. Let me point out, and I actually put it, I don't know if I put it in this testimony, but children with autism or whatever category they're put in by the DOE, they don't necessarily count everyone with autism because they'll put it by category. And in fact, that's one of the bills being heard today. I think it's SB 105. This is a concern because The DOE doesn't know who has autism if an IEP team chooses another category. And they choose another category because it's enough to get them eligible. And they aren't counted if the SB 105 passes. They don't want to count these children. So what I'm trying to say is that Medicaid has coverage for certain types of reasons, whereas the school uses ABA for other reasons. So they don't combine unless you follow the Medicaid procedures with the DOE.
Okay, and that's, but
Yeah.
another way to ask the question, did
Yes.
he receive any ABA services through the DOE? Or any behavioral health services, maybe not ABA, through the DOE?
Oh, definitely ABA, because when you look at behavioral health, mental health, that's different than ABA. Yes, he did. He finally got qualified later in life when he should have been qualified earlier because the school decided he had Down syndrome, not autism. That prevented him from getting ABA in the school. When the ABA law passed here, we're very grateful. I didn't know what ABA was, even though it's been around for quite a while. He qualified through insurance, through Medicaid.
Okay, and then received it.
Yes, and then the DOE took notice, realized, hey, he can do stuff. Right now, it's not the best situation. Presentation because he's not had his support since end of December. So he definitely has been here with his registered behavior technician. He's been to hearings. He's been able to be here. Me, I'm mom. He doesn't want me to be here, but he still has that learning. So the DOE, the last year, yes, he got educationally based types of ABA services full-time because he needed it, and he learned quite a bit, actually. He's come a long way, and he has more potential, and it would only be through the ABA services. But again, the last year, Medicaid ended at 21. He still could be at the DOE for another year, even though the DOE is the Medicaid provider. They wouldn't have been able to bill for it anyway.
Okay, thank you. That's the questions I had. Thank you, Ms.
Thank you very much for your time.
Other questions? Oh, yes, Representative Kobayashi.
For,
And you had a
I
follow-up
guess,
question, right?
DHS.
Okay,
Your testimony says that you have insufficient information to determine the fiscal impact of this bill.
Correct.
And the prior testimony from DOH says that the services provided would be 100% state funded.
It would be 100% state funded if we cannot find, if we don't have them, if we don't have the services as being either determined as medically necessary or as clinically appropriate. So we need to do that research, which is what we had included in our testimony.
What might that cost be in ballpark figures?
Oh, so the bill itself includes not just ABA, but there's a broad range of services for a broad range of conditions. It's any neurodevelopmental. So at this point,
everything.
I don't have a way to put, it could be anything from 30 million to 100 million. I don't, honestly, I don't know.
Okay. If we pass this bill and we don't give 30 million to 100 million, what would the result be? A lawsuit requiring the state to fund the services per this law or per this bill?
I don't know what the ramifications would be. It's requiring us to write, all the rules and policies and requiring us to turn in a state plan amendment. We are trying to note that we're happy to do all the research, to look at what policies might be possible, and then come back with a recommendation or with possibilities of what we could do, both within the DD program as well as within the regular Medicaid program.
And you could do this development of rules, policies, procedures.
We could research it. I would hesitate to write rules without, I would hesitate to turn in a state plan amendment without the appropriation, if, you know, so I think that we should, it should be recommend instead of shall. It shall, you know, DHS and DOH shall research what rules, policies, and state plan amendments would be necessary for updating this, for providing these kinds of services, but the shall write the rules, shall write the policies, and shall submit a state plan amendment is problematic given the breadth of what's included and the breadth of what we're being asked to do without having any ability at this point to do the work to even provide a fiscal.
Let me get back to the dollar amount. The $30 million to $100 million.
That was a guess.
Yeah.
Okay.
I mean, in your program, a guess is, you know, 9 digits.
Yes, it usually is, at least.
Is that 30 to $100 million, give or take, whatever, all state funds?
If it would be dependent on, I would imagine that some would not be just, you know, straight state funds. Again, if we turn, for example, we turn in a state plan amendment, it's approved, that means that we can get federal match, federal Medicaid match on it. If we, if the requirement is to write rules and come up with the policies, submit the state plan, but then we don't get approval, then yes, of course, that would be all straight state funds. I would imagine that some of these services, you know, medically necessary, we would be able to come up with a rationale. So we would be able to come up with we would be able to come up with an approvable state plan amendment to provide some of those services. But again, we need to do the research in order to outline it and come back with some recommendations.
Okay. No, what I'm trying to figure out is you gave a dollar number, a very ballpark dollar number, 30 million to 100 million.
Mm-hmm.
Normally, Medicaid is something like 45, 55%.
That's correct.
Split,
Mm-hmm.
state, federal. Does the 30 million to 100 million dollars include just the state portion?
No, it would be the total.
everything?
The total.
The whole
It would
thing?
include the federal match.
Okay,
Yeah.
thank you.
Mm-hmm.
Further questions?
Thank you.
Okay, Chair Bellotti.
I have questions for Dr. Lee, but then Dr. Moore-Peterson, if you could just stay to the side. Is there anyone from the Developmental Disabilities Council here on Zoom? Okay. I'm very concerned, Dr. Lee, that this bill is, while it's needed, it's too broad, and that it's not something that we can really grasp our hands around. And so I guess I'd like to ask you the question about the term neurodevelopmental disorders as one of the kind of constraining terms in this bill. Is there a better term to be using to capture the population over which the State Council on Developmental Disabilities may be concerned with?
I don't know what the intent is of using the term neurodevelopmental disorders, but I too am concerned about the broadness of that. So it may include such disorders as ADHD or specific learning disabilities like dyslexia, and also individuals with autism or intellectual disabilities, cerebral palsy. And the concern is that ABA hasn't been studied or researched in those populations significantly. So for a better term, I'd have to get to the intent of what the state council wants out of the populations that they want to treat.
Okay, flip side of it is, because there's an amendment floating out there, friendly amendment, but again, I don't know, because again, this could expand the reach of this, but is FASD, fetal alcohol syndrome disorder, considered a neurodevelopmental disorder?
Yes, I mean, I think individuals with developing brain disorders caused by a number of things, fetal alcohol exposure, drug exposure, et cetera, may be included in such a neurodevelopmental disorder definition.
Okay.
Because it doesn't specify the cause. There's many genetic causes also.
Flip side of that, if the intent is now just to focus on autism spectrum disorder, which we believe, and I could be wrong and you could correct me, that's a more widely spread or a widely existing disorder within the community, so that would rise to the level of it maybe being the one that's drawn out and for us to focus on. So if we were to limit this study on that, is that also an accurate kind of understanding?
I think autism was drawn out because ABA was primarily studied in autism, and it has not been studied in the other neurodevelopmental disorders. I'm uncertain why they included upfront neurodevelopmental disorders, maybe to broaden it beyond autism and the reach beyond autism. Autism occurs in 1 in 50 individuals, and so it's quite prevalent in our community. But to broaden that reach further to populations such as fetal alcohol spectrum disorders who have not been diagnosed with autism might be the intent of the use of neurodevelopmental disorders.
From your medical background, is FASD more extensive than autism?
Yeah, that's a tricky question. You know, most of FASD goes undiagnosed, and so some might argue yes, and others would say no.
Okay. Thank you, Doctor. My next questions are for Dr. Moore-Peterson.
Good morning.
So I think you can see where I'm going with this, potentially, to try to
Maybe.
limit
I
and
don't know.
constrain.
Not positive.
I have some questions about the 1915C home and community-based waivers for individuals with IDD.
Mm-hmm.
What is the age for that group of people? Who applies, who in that group?
I can answer that.
Oh, okay. Sorry, is that a
Sorry.
DOH?
We can answer things together.
Yes, okay, thank you.
So,
We can both stand here.
So for the DDD waiver, it's all ages can apply and be eligible.
Okay, and then the EPSDT benefit of plans.
That's correct. That's up to 21.
Okay.
And the way that CMS has defined that, has defined EPSDT and the ABA benefit for kids, or for autism, ABA is through it's not through the 1915C. So it's provided through the Quest integration through the health plans.
Okay, so home and community-based waiver for individuals with IDD
Mm-hmm.
is all ages, including adult ages.
Correct.
And under that program, is ABA available? Can you explain why?
It's not available through the home and community-based waiver because it's provided through the EPSDT benefit through the health plans.
Okay.
And that was that was what CMS has essentially told us. You cannot duplicate the services. If it is an EPSDT benefit, then it is the Quest integration, the regular Medicaid program that's responsible for all things EPSDT, and you cannot essentially double pay for it under the DD program.
Okay. Here's my question about EPSDT.
Mm-hmm.
Knowing that the Department of Education has jurisdiction and authority over essentially children up to the age of 22, if this was broadened to 22 years of age, how does that affect anything that might be happening with students who are under DOE jurisdiction and may be qualified for Medicaid services through DOE?
In other words, instead of starting, I think because the way that this bill is written, it's starting at age 21, which is the ending of the EPSDT benefit. I don't actually know, I'm not an expert, unfortunately, on the DOE side of things, but from my understanding, those services are educationally related, and within the EPSDT benefit, on the Medicaid side, we want to make sure that those that everybody gets those services regardless of whether the person is receiving those services in the schools or not. They're looked at it's not independently, but we just need to make sure that under the EPSDT that we're able to provide all medically necessary services. I don't have a way to be able to respond back to you regarding, well, what if you change it to 22? Because I don't have the familiarity with the types of services that the DOE is providing.
Okay, let me ask the question this way then. For students who receive ABA services in the public schools and are Medicaid qualified, my understanding is that there can be Medicaid reimbursement for some of those. So that doesn't come under the auspices of the EPSDT program, does it?
It does not, in the sense that yeah.
Okay, and then the idea would be that if those students, again, talking about this DOE population, if they have services outside of the school, outside of school hours that are medically necessary and maybe ABA services, that's what EPSDT covers for them in their lifetime outside of the school.
That is correct.
But then inside of the school, when they are in school and they have various psychologists, EAs working with them, possibly teachers who are engaged in the practice of ABA, there is also Medicaid drawdown for that potentially because they are Medicaid qualified, as well as they're receiving services in that setting that EPSDT would not cover. Is that correct?
It's potentially, I'm going to answer the one narrow piece of that. It is potentially billable by the DOE.
Okay.
Yep.
Then the final question is, this probably is something we should have seen coming as we passed the insurance mandate. And that was a clear policy choice by the legislature then to cut it off at a certain age.
Mm-hmm.
But as we've seen this develop nationwide, there's indication in the testimony that in fact, more and more states are looking to cover it for more and more adults. Is that accurate?
I don't know. I'm sorry. I've just been focused on Hawaii and what's covered here, at least for the commercial. I do understand from talking to some of the advocates for this particular bill that they do struggle on getting services for their, for their older kids or for adults from their health insurance, from their commercial health insurance. So I do, even for kids over the age of 12.
Okay. All right. I think though that it does kind of flag maybe the need for research to understand what is going on in other states and the policies. Because if this saves money in the long term, right, then it is possibly something that's beneficial for community in general. But thank you for the answers to the questions.
Well, I had a question for Dr. Judah Moore-Peterson. Yep. So I know that the bill has both Department of Health and Department of Human Services together, especially in sections 1 and 2, but it's got to be Department of Human Services that has the Medicaid program that you represent that would need to make a request to CMS for approval of matching federal funds to try to cover such services for people in this bill. Is that correct?
That's correct.
Have you done that? Request approval from CMS to see if we can provide federal Medicaid matching funds to help this group.
To help the over 21 for
yes
for autism?
Yes.
Not yet. That I could think of, but I don't. you know, our state plan is hundreds of pages long, and it's, I'd have to go back and ask my team, hey, what's in there for these services?
Do you think, Doctor, it may be more prudent to maybe change this bill to a task force or a study group to look at what needs to be done, meeting with the advocates and stakeholders, and if everyone comes up with a plan, perhaps then bring up a plan of action for CMS to look at and hopefully approve. I don't think my committee, I don't think we feel comfortable with the bill as it is, but I think there is some merit to cover a lot of the people, neurological disorders here. I think we need a little bit of time, but I'm wondering if Department of Health and Department of Human Services could work with some of the stakeholders and maybe come up with language and maybe request CMS approval. So maybe next year you can craft a bill for us to look at, to try to move.
We would be happy to work with the proponents. There's actually been work that's been happening over the years. We're happy to get back together again, try to work on this particular topic. We understand that there are gaps. We understand that the services can be difficult to manage and to navigate and to figure out how to get what. We probably would not draft a state plan amendment until we had a good understanding about what the services were, what the costs were, et cetera. But we could draft it, but we probably would not submit it to CMS. But sometimes
looks to be that we just need time to meet with everyone.
We could meet,
craft something.
We could take a look at. I just heard, today it's like, oh, New Mexico's done this, so we could research and talk with other states. I could talk with some of my colleagues about the provision of these kinds of services for people 21 and older.
I really want to continue to support the advocates of this bill. I just think it's premature. However, I think it doesn't preclude us from perhaps, again, I'm going to repeat myself, changing this to a task force, or even Department of Health can work side by side with the advocates of this bill. And if you see fit, then maybe do make a recommendation to CMS for services to be covered, and do craft a bill for us to look at. Again, without the departments and the advocates working together, we're never going to come up with solutions. So I think at this point, really need to put a pause on this and maybe take a look at it from maybe a study group or a task force would be the more prudent approach.
We're happy to work with a task group. We're happy to work with the proponents of the bill.
Okay, thank you. Thank you very much, both to you and Department of Health. One last question, Ms. Darlene Chen Scoville. Thank you. Come on up. I know you've been an advocate for years. You've also served as a special education teacher at the DOE.
I actually I was under ABA. I work with children with autism. And in my practice, I have seen so many children with autism that are FASD. My theory in that is that clinicians diagnose them with autism because there's services, because FASD has none. And I have seen so many of them. I've worked with children with autism for 8 years, and it's a neurological damage caused by alcohol during in the fetus when a mother is pregnant and consume alcohol. So it's a distinction. There's a lot of overlap, yes, indeed, but the difference that I see in my experience is that autism, children with autism have visible features and behaviors and things like that, while FASD has none, and that's the really tricky part of it. And thank you, Doctor.
Doctor had mentioned that from Department of Health.
Yes, right? And that's the real challenge. And I'm here in front of you today that there's the neurological damage of the brain autism has and FASD has, and the thing about it is that I believe that FASD is more prevalent only because they go undiagnosed, because they look just like you and I.
Well, doctor had mentioned that too, that many times they're just not diagnosed.
Correct.
Now, what's the national average?
The national average is 1 in 20 first graders have FASD. And this is not only nationally, it's also global. So globally, they're starting to take a look at it as a problem because alcohol and sex is never gonna go away. And women do not all have regular menstrual cycle. So there's a lot of unintentional pregnancies all over the world, not including
Unbeknownst
us.
to the female, and she
Correct.
has a drink.
Correct. And I think I think these children, I call them forgotten, not fall into the cracks anymore. It is disheartening, and sometimes I feel like I wanted to cry because their own mothers cannot come forward to fight for these children because of the stigma surrounding this issue.
Darling, with this bill, I think our committee is pretty much, we pretty much are in agreement that it's just not ready to go.
Okay.
But would you be able to work with both doctors from the Department of Health and Department of Human Services, as well as those with Down syndrome, autism, all the other groups on crafting perhaps policy that could be covered, hopefully by Medicaid? And that's, if you work with Dr. Judy Moore Peterson, eventually she can draft up a plan to see if CMS will approve that, and if we can use federal Medicaid funds to help with so many of our people, not only with FASD, autism, but so many others. Are you okay with that?
I've said this so many times over the years. Use me, I'm free. I'm a volunteer advocate. I don't charge anything. I am just doing this to better our community and supporting those children that are forgotten.
And you're okay with working with Linda and all the other advocates, not only with
Absolutely.
FASD,
More
but
than happy to.
Okay. Linda, are you okay with that?
Yes,
Okay. I'll recommend that we task force this again, because the bill is not ready to go. We understand that clearly, but I think there's merit to this. We really want to cover our keiki. And by the way, if I have autism or FASD when I'm 7, well, if I'm 37, I still have it.
Correct.
So we really need to provide
It
better
doesn't go
services.
away.
Yeah.
You can be 77 and still have it.
Right. And that's why I appreciate Linda's testimony too on your son. Let's work together. I think
Yes.
that's going to be our recommendation to
Absolutely.
put this in a task force. Okay. Thank you. And
Thank
Department of
you.
Health and Human Services, thank you
so
also.
much.
Yes, question for Vice Chair Amato.
I have a quick question for DHS.
DHS.
About how long does it take to get approval from CMS to include these services, to get coverage approval? How long does it take to change policy with them?
Mm-hmm. Well, it depends on the complexity of the topic,
Let's do that then.
but usually from start to finish, if things move smoothly, it's about 6 months. If things don't move smoothly, it can be a lot longer.
I see. So technically then, conceivably, if we form a task force and everything goes perfectly like it's supposed to, then we could potentially have approval from CMS 6 months to a year or so.
Correct.
Okay.
I do want to note, though, that, again, just to reiterate, that if we get approval, it means that we are covering those services. And so, therefore, we would require that we'll be doing a fiscal at the same time, right? And so we would require an appropriation. So before we submit anything, we would want to make sure that it was well understood about what the cost would be before we gave it for formal approval to CMS.
Got it. Thank you.
Mm-hmm. Thank you.
Thank you. Hey, further questions, members? Okay, if not, thank you, members. We're going to move on to the last bill on the agenda. That's going to be Senate Bill 894, Senate Draft 2. First up, Department of Public Safety. Provided testimony in support. Kamehameha Schools. Testimony in support. Executive Office on Early Learning. Provided testimony in support. Department of Human Services.
Good morning, chairs, vice chairs, members of the committee. Kathy Betts, Director for the Department of Human Services. We're in strong support of this measure. We'll gladly work with the Office of the Governor to facilitate the transfer to DHS. I will note that the department is in strong support of the critical need for trauma-informed care and resiliency services, especially on the heels of a global pandemic that we've seen impact our youth in very, very disproportionate ways. I'll also note that we are very concerned about the recent CDC report that came out highlighting the dramatic increase in our youth that are contemplating suicide and self-harm. And so we'll continue to look at this, as well as the ability to strengthen the trauma-informed care for our staff and self-care for our staff, so that we can continue to do the oftentimes difficult work that we do. And we thank you very much for hearing this measure.
Thank you, Director. Thank you very much. Next up, we've got the Hawaii State Council on Mental Health. Provided testimony in support. State Department of Health. Department of Health. Provided comments. Hawaii Youth Services Network. Judith Clark.
Not present.
Oh, okay. Provided testimony in support. PAC, or Parents and Children Together. Testimony in support. Hawaii Primary Care Association. Testimony in support. Hawaii Kids Can.
Aloha chairs,
Aloha.
vice chairs, and members of the committee. Thank you so much for the opportunity to testify. We stand on our written testimony in strong support of this bill. As an education nonprofit, we've seen firsthand just how much trauma-informed education is needed, and we think this bill and this broader office will make a foundational difference for our kids. So thank you very much.
Thank you very much for your testimony. Next up, Epic Ohana. Testimony in support. Hawaii Children's Action Network speaks. Testimony in support. Hawaii Community Foundation. Testimony in support. And I've got 7 individuals with testimony all in support. So if there's anyone present or on Zoom that would like to provide testimony, please come on up.
Hi, aloha chairs, vice chairs, and members of the committee. I am Rian Rooney, here today to just express my support for Senate Bill 894, Senate Draft 2, relating to the Office of Wellness and Resilience. As a resident of Hawaii, I believe it is important for the Collaborative Task Force to continue their work to provide recommendations to the state in developing trauma-informed frameworks. This is especially important given the unique challenges that Hawaii faces. By prioritizing and taking a trauma-informed approach, recognizes the multifaceted experiences of people to provide improved support in how we can build a stronger and more resilient Hawaii. I greatly appreciate your folks' consideration in support of Senate Bill 894, Senate Draft 2. Mahalo for your folks' time and consideration and opportunity to testify today.
Thank you, Rayan, and we do have your written testimony. Thank you. Okay, please come on up.
Aloha, Tia Hartsock, Executive Director, Office of Wellness and Resilience, Office of the Governor, provided testimony and support, and here for any questions. Thank you.
Okay, Tia, I'm sorry, I don't see your testimony. Did you submit late testimony? Did you submit testimony? Okay. You see it? Oh, we do have it online. Sorry about that. Thank you, thank you. Okay, that's, I believe, all the testifiers, unless there's anyone else wishing to testify. Okay, members, questions on Senate Bill 894? Questions? Representative Kobayashi?
I guess for Department of Health, but Department of Health is not here?
Well, we have a representative, but they're... I think would you be able to answer?
It's not there.
Well, maybe for the Office of Wellness.
Okay, Tia can answer that, hopefully. Yeah.
The bill talks of, no, the bill states that this office shall be established within the department for administrative purposes only. The task force, similarly, would be within the department for administrative purposes only, and same with the so-called advisory board.
Let me, oh, go ahead, sorry.
I think that, why do you want administrative purposes only?
So the Office of Wellness and Resilience is currently in the governor's office. The task force is Act 209, Session Laws 2021, and the chair of that task force is Department of Health. The bill is a housekeeping bill requesting that that task force turn into an advisory board and stays connected formally to the Office of Wellness and Resilience to provide ongoing advice, support, utilize it as a collective body of stakeholders that are providing community voice. The task force meets monthly right now and is developing a framework for the Office of Wellness and Resilience to implement to create a trauma-informed care state. So that
do you understand what the words "for administrative purposes only" means?
So when the request is when the Office of Wellness and Resilience is to transition out of the office of the governor, because no office can stay permanently in the office of the governor. It has to transition over to a department. So it would be transitioning over to, the request is to transition over to Department of Human Services. That's my understanding.
To the Department of Human Services?
Correct.
Not the Department of Health?
That was the requested amendment, yes.
I'm sorry. You want this bill amended so that this office would not be established in the Department of Health?
That it would transition to Department of Human Services in July 1st, 2025. Yes.
Now, do you understand what the words "for administrative purposes only" means?
For purposes of like the administrative services that are attached to an office, so staffing, budget, they're administrative pieces of having an office established. So similar to Executive Office on Early Learning and Executive Office on Aging, I believe both began in statute and then were housed in the governor's office and then transitioned over to Department of Education and Department of Health, respectively.
My problem is that, generally speaking, when you use the term "for administrative purposes only," this means that the office is independent of the director of the department.
But administratively attached.
I'm sorry?
Administratively attached.
Yes, but this means that the department has no policy oversight or input.
Like a semi-autonomous agency.
Yes.
Yes.
And you want that?
Yes, that would be preferable. Similar to the model of the Executive Office on Aging and Executive Office on Early Learning. That was the model that the task force was looking at.
Isn't the Office of Wellness and Resiliency supposed to coordinate and help with the big picture overview of a large number of services?
Yes, lifespan services and coordinating cross-state systems to address trauma-informed practices and delivery of the framework, yes.
I see. I would think that you would want to strike the words "for administrative purposes only," because working within and with the department might be a more effective way of providing this, shall we say, big picture oversight, coordination, etc.
And that was one of the reasons why we're asking for an extension in the Office of the Governor, to be able to further kind of get our approach more solidified, look at coordinating with the departments for another year, because this was established July 1st, 2022. and an executive director wasn't named until January, of 2023. So we're looking to kind of establish the protocols, look and see how we can coordinate across the state agencies with some authority to be able to better coordinate the reform efforts around trauma-informed care.
Okay,
But
thank you.
but I appreciate the comment, and I will definitely look into it. I'll address it with the task force.
I think that this, for administrative purposes only, puts you as a outsider in the department, sometimes even perhaps antagonistically so, and is counterproductive to your overall effort to provide a big picture oversight coordination role.
And I think that we can have an ongoing conversation too with the departments to see what the best approach might be, because all the departments are on the task force and are part of this conversation on what would be the best kind of positioning for the office, how it would be most effective in its delivery as an ongoing agency. So that I'd love to have more of those conversations.
I mean, having the departments represented on the task force is irrelevant so far as making policy recommendations. Okay, thank you.
Okay, if I could look
Tia,
more
yeah,
into
please
that.
stay up.
Yes,
Chair Bellotti has a question.
yes.
I am respectfully going to take an opposite direction of my senior and well-esteemed colleague on this committee, because I actually think that you want to keep administrative purposes only. And then the question as to who appointed you, because this office is in transition, it's really kind of quirky at the moment, but in the proposed bill before us, the office will be headed by an executive director who shall be appointed by the director. So actually, the director does retain a lot of control over the office because of that appointment authority.
Currently, it's the appointment of the governor, and when it transitions, yes.
It will then be the appointment of the director. So actually, there's actually more teeth to this. Now, so then my question goes back, and again, recognizing that this is in transition, you were selected in January 2023 by Governor Green.
Correct.
Correct.
Actually, it was officially December of 2022, but
Okay.
started in January 2023.
Okay, so this movement to Department of Human Services, I think, is wise. I think there's a lot in flux at the moment. A lot of your task is to develop trauma-informed policies, and I think like the work that's being done in Senate Bill 1351, that is at the beginning of this agenda.
Correct.
I actually think that would be embedded and would be better embedded in your office, where you would take the lead because of the connection with trauma-informed care. This is a lot to say. That how many positions do you currently have associated with the office?
6 currently.
6, and they're all generally funded
Correct.
through. Are they in the state budget, or are they in a bill?
This year, right now, my budget ends June 30th, 2023. It was from the administration, but there's currently part of the governor's request for the biennium is to have the positions funded through the governor's budget in general.
General fund, so it'll be in the
Correct.
state budget. And did that pass
Correct.
through, and I apologize, did that pass through into the House budget?
I believe so.
Okay, so it's in House Bill 300. We
yes.
will follow up on that.
Yes, it is.
Are all of those 6 positions, have they all been filled by you already, or are any of them vacant?
So when I started in January, started to establish my position. It was hired into a temporary position. My position got established at the end of January, beginning of February. I then submitted 2 more position descriptions. One position is getting filled tomorrow. The next position is getting filled next week, Wednesday. And then the 3 positions that are remaining are the position descriptions have been submitted, and they're getting developed right now in DHERD, Department of Human Resources. As soon as those get established, they will be filled.
What are the 2 additional positions that you've picked up?
That I've currently.
Yes, that you currently say
One
you're
is the administrative assistant position. That person starts next week, Wednesday. And then a social marketer communications starts tomorrow.
Okay, one of the things I'm concerned about is that, you know, again, the work that's identified in Senate Bill 1351 would already fall under this office. So we are now going to be adding another position in that bill, plus the 3 additional positions you have to fill. So now and I think we need to streamline some of this, because the people who are working on some of the early intervention stuff, it overlaps with the people who are in this very same bill. What are your plans to kind of have that integration occur? Or is there no plan?
So I was just informed that amendment or recommendation would be for Senate Bill 1351 to be in the office. So I don't have thoughts on that yet. I was just informed about an hour and a half ago.
Okay, maybe another way to ask this question, those 3 remaining positions you have yet to develop?
Yes.
What are those supposed to be?
So those are planner positions, and those are looking at the lifespan of policy development, looking at community outreach, looking at coordination of the current reform efforts across the state departments. So planner positions.
Okay, so that actually sounds exactly like what they might need in Senate Bill 1351.
It sounds similar, yeah. But those positions would be specifically, right, the focus would be on 0 to 5. So the thought for these planner positions that I'm establishing currently would look at the different populations, hoping to house 1 on the neighbor island, 2 on the neighbor island and 1 on Oahu. So that's the hope. And depending on what type of applicants come, looking at their skill set and history of employment, see which ones would best fit with which age spans. So the planner positions, or the type of position, the coordinator positions that SB 1351 is looking at, would be obviously looking at 0 to 5, and that could be part of the purview of the office as well.
Okay, you know, I guess I would make one comment and let you respond. We've seen a number of bills actually coming from the governor's office and then different departments of the governor's office, all kind of dancing around all of these topics. And we're adding positions here, adding positions there, putting positions here. You already have positions that are not yet filled. There seems to be a lack of discoordination or uncoordination amongst the executives. And I think we have people here who want to help and support, and we have community clearly that wants to help and support. But I would really strongly urge that there be more meat to what you folks are doing and coordination amongst the agencies, because it feels very piecemeal right now. And it feels like we should be holding back on certain things and let you guys do the work you need to do to establish before we start running down these other things that raise the community's expectations unreasonably. And then everybody's made to look bad because it looks like we're not responding.
I'm excited to get staff on to start coordinating some of these pieces. I've been meeting with departments and community advocates and community nonprofits on the approach, what the needs are, because our purpose and our function of this office is large. And so getting the content areas, specialties, there's a lot of coordinating bodies that are currently doing some of the work and are very interested in the collaborative approach. So those conversations have already begun and continue through the task force meetings as well. So I'm hoping that as I get staff on and we can more appropriately coordinate that'll start coming together.
Okay, and I would really greatly urge you as we head into conference,
okay,
because there's all these bills floating, and again, they're all dancing around the same topic. It seems to me that this is actually the priority. This is the priority versus all of the other ones where we're piecemealing things. And that if you get this one set and the direction of the office is set, then you can start to identify and tackle and prioritize all of those other things. So I just urge you folks to really look at what's going into conference and then focus.
Thank you.
Because then we create better expectations in the
Yes,
community.
yes, and that's one of the biggest reasons is shaping the expectations so that we can have the conversation in a way that is going to meet expectations and not. That's why one of the positions is the communications person's coming on to help shape the expectations of what the office can deliver immediately and how it can be delivering over the next.
I think communications is important, but substance is more important.
True.
Substance is way more important than communications, because if there's no substance, then it doesn't matter, because we're not creating government that actually works. We're just having photo opportunities.
We are looking at substance in terms of, she's specifically looking at how to facilitate and have conversations with social justice issues that are specifically around trauma-informed care. So she's been working on the task force for the last 2 years with me, and how to coordinate those conversations to get the needs from the communities is particularly her expertise.
I think there also needs to be communications with your department heads. That's what I'm getting at. Coordination and substance.
Yes.
Is really, really important. Thank you.
Thank
you,
you.
Chair.
Yeah, Tia, stay there for
Yes.
a second. Members, further questions? Kobayashi, Representative?
I would modify my comments given Representative Bellatti's question. I think that having this office, this advisory board for administrative purposes only within the department has both good and bad situations.
Sure.
I mean, to have a group that doesn't provide services but advises, addresses, identifies, seeks funding solutions is kind of like having the horse semi-detached from the wagon, so to speak. That is, you're going to be in a department advising, identifying, seeking funding solutions, but perhaps in this coordination with the department, which may be good if there is a known problem and adversarial, shall we say, confrontation needed. But I think maybe that's the intent, to have a adversarial body doing this, addressing, identifying. Thank you.
Thanks. Further questions? Tia, I had a question. I apologize. I know Department of Health is not here, but I'm a little perplexed. I need some help on this.
Okay.
So in the testimony by the Department of Health, they're saying that they're very supportive of the bill. They want to change the advisory board to an advocacy board, which is fine. We can do that. But here's my question. They're saying that they also want to adopt and this is the word they use, sooner. They use sooner. Transition of the Trauma-Informed Care Task Force to an advocacy board before June 30th, 2024. So I mean, what does that mean? Like June 30, 2023? They just said sooner. That's the only word they use, but they didn't give us any date. They just said sooner than June 30th, 2024. Do you know what?
So I've had conversations with Department of Health, and they're looking at providing some comments around having it turned into an advisory board. I think it was more closely related to the recommendations report being due. The recommendations report due date is for the task force is due on in December of 2023. So the bill doesn't ask for an extension of the recommendations report. That will still be due in December of 2023 to provide to the legislature before the 2024 session. And so I believe their comments is talking about pushing it to an advisory board and looking at the dates
Are you sure
before
advisory
that was
board?
due.
Because clearly they're saying they want to change the advisory board to an advocacy board. That's what I have. And they're saying that they wanted to change they wanted adopting a sooner transition of the trauma-informed care task force to an advocacy board. That's the words that Department of Health is saying. We want to help. I don't know when sooner is. So if nobody tells us, we're just going to leave the date as is, June 30th, 2024. We're not going to do it any sooner unless I know a
Correct,
specific
right,
date.
yeah.
Okay, I guess this is a work in progress. I think all of us need more clear answers as we craft this bill. Because again, we want to work together.
Okay, great.
Make sure
Yeah.
the policy is airtight
Yes.
and it's going to be legally a good bill. But I think we're just a little bit of ways from having a perfect bill. But we'll work with you.
I know Lauren was here, so I'm not sure if he's.
Yeah, if you can connect with
coming
Department
back.
of Health, we're willing to
Definitely.
take
I've been talking with Lauren
of their amendments. Like
regularly.
Lauren Kim, yeah.
Yes.
We're willing to take some, if not all of their amendments, but again, we need the rationale behind some of it, and even the dates. If they're saying they want to do this advocacy board, transition the advisory board to an advocacy board, if they can give us specific dates, that'll help us in crafting the bill.
Okay.
Because we can put that in the bill. At this point, it's just, they use the word sooner, and
Right.
it doesn't give me a specific date. Yeah, oh, yes, Chair Bellotti.
Okay, can I ask this question?
Yeah,
If
of
we're gonna
course.
if we're gonna send it to the Department of Human Services, why don't we ask the Department of Human
Right.
Services whether they'd rather have an advisory board or an advocacy board?
Well, yeah, the director's here.
Yeah.
And really, frankly, the
good
Department of Health
idea.
doesn't have a say in this when we transfer it to the Department of Human
it's going to
Services.
the Department of Human
Yes,
Services.
so what would you rather
Director,
have?
you're on the spot.
We have various attached commissions, HPHA is attached to us, Office of Youth Services attached to us, Commission on Status of Women, Commission on Fatherhood, LGBTQ Commission. So I think it was wise to put OWR in the governor's office so it can have some gravity and weight and some guidance from Governor and his team. And I'll just preface this by saying that I am the co-chair on the Trauma-Informed Care Task Force that originated the idea of an Office of Wellness and Resiliency. So Tia does, when she was the other co-chair on the Trauma-Informed Care Task Force, she did have all of the department heads at the table. So we have been coordinating on this for quite some while and working on, developing guidelines and recommendations and objectives and really helping to get the word out into the community that this is important for this administration. So I would defer to however the ED would want to be attached, but I'll say as a former leader of an attached agency with DHS, I worked in concert with the former directors of DHS and with all of the attached agencies that we do have within the department right now. We all work pretty closely together and in concert as one team when there are issues that arise about, if there's something adversarial or something we don't agree on, we have conversations about them. So I don't think being an attached agency is a bad thing. I do think it gives you a little bit more autonomy where they don't necessarily have to draw the department party line, if that makes sense. They can venture out and have different ideas and different approaches that aren't necessarily consistent or something that I would recommend, but as long as it's, helping individuals in our community, we would support that.
Okay, I think so you got us. I feel like maybe the transition to Department of Human Services is kind of, there's consensus around that. The question is about the board itself or the task force. Should it be an advisory board or an advocacy board? And then whether the chair should be a non-state employee chair. And I guess maybe to draw upon your experience from the commission, I think advisory has certain connotations that may have greater obligations, and maybe that's why advocacy board would be better. And then who chairs it, if it's a non-state employee, that also may be less legal obligations. But can you speak to any of that?
I would be fine with an advisory board. And I do agree, Chair, that having a non-state member as one of the co-chairs is important. It lends a significant and important voice of the community that can be very sometimes different than the state's perspective. I think that having a community member brings different perspectives to the table, which is important for something like this because it does impact our community.
I was going to actually see if Kathy wanted to be the chairperson, but it sounds like it might be better that we get a non-state employee. You know, Director, so again, this is not from you, this is from Department of Health. So your thoughts are, they're saying, according to Department of Health, they're saying that the amendment for this bill that they're recommending is changing advisory board to advocacy board. So Chair Bellotti had an excellent question. I mean, I guess the question both of us have, or all of us have, is it better to say advisory board or advocacy board? What?
Chair, I don't know the impetus for this recommendation, but they sound very similar to me, and without any definition in statute, I don't know what would be the difference between an advisory and an advocacy board.
Okay.
I think they're very similar, so I'm not sure of the reasoning.
Okay. Tia, would you happen to know why they're asking the Department of Health, that is? Because they're not here, and so we're trying.
Right. I would agree with Director Betts. I think there's little difference. So the task force created the word advisory, so that's why we put that in. And the task force is comprised of many departments and nonprofit community members, and several community members that were involved in that conversation. So,
okay, I guess we'll try to figure it out. We get it though. I mean, I think our entire committee gets it. This is an important bill. Don't get me wrong. And that's why I think we've got so many questions, because we want to make sure we lock down on a good piece of legislation. We don't want to send out anything bad. So yeah, we'll work with you on this, and our committee members will work together. But this is an important bill. We get that.
Thank you.
And Director Betts, thank you for being, honored to take this under the Department of Human Services. We appreciate that. Okay, members, Representative Kobayashi.
Sometimes, names are important and sometimes they're not. Like this difference between advisory board and advocacy board. I mean, until you define what advocacy board means, it's a meaningless change. I have another question involving definition. The Office of Wellness and Resiliency is supposed to work with trauma-informed care. The so-called advisory board is supposed to define what trauma, create, develop, and adapt a statewide framework for trauma-informed responsive practice. It seems that maybe the two terms, wellness and resiliency, and the term trauma-informed care gets mixed up. And maybe people would have a better idea of what you're trying to do or should do if there were either a definition or a merger of the two terms.
Thank you for that question, because that was a very deliberate decision. First of all, just personally, I think creating an office, we looked at many, many models across the country, and many states have different models of what an office of trauma looks like, an office of wellness, an office of resiliency. There's many different titles in several states currently. And what we wanted to do is really look at how within the field of trauma-informed care, a lot of the work is starting to push towards building on resiliency versus focusing on trauma. And so the language was very important to us. I'm not sure how many people I could get to work for the Office of Trauma versus the Office of Wellness and Resilience. And so just the kind of optics of what the focus of the offices, we're really trying to look at the strengths-based perspective and look at best practices for treating and addressing early trauma, and looking at interrupting trajectories that are impacted by negative and adverse experiences of trauma. And so the language, according to the Substance Abuse and Mental Health Services Administration and the Department of Health and Human Service and the federal agencies are really looking at how language is used in the state. They're starting to really further define what those pieces look like, what the elements and measures of best practices are. We're working, actually, I'm already working with the federal agency, SAMHSA, to, as they have an interagency task force currently operating, looking at definitions and advising and informing the states on how we should be interpreting some of their definitions and how we should be operationalizing, measuring, and being able to look at best practices. So there's already a lot of coordination with the feds, but in terms of language, we really wanted to have it focus on a strengths-based approach versus kind of putting more voice to the traumatic experiences that people experience and looking to see how we could increase resilience and build wellness across the state.
Is trauma-informed care defined anywhere?
SAMHSA has a definition for trauma-informed care. Substance Abuse and Mental Health Services Administration within the Department of Health and Human Services in the federal department. They have defined for the states.
They are irrelevant. Is there anywhere in state law or state policy?
The task force is currently coming up with it has come up with a definition, and as a part of their recommendations report is a new definition for our state on what trauma responsive practice looks like. We've also adopted the terms that the federal agencies have created, SAMHSA has created for trauma-informed care definition.
As of now, there is no place in state law or state policy where the term trauma-informed care is defined.
That's a great question, and no, I don't believe there is. And so the recommendation from this is what the task force is working on right now, is defining what this practice looks like, defining what responsive practices are, and so they've already come up with a recommendation for a definition. And that will be part of the recommendations report for the legislature at the end of this year.
So, given what's in this bill, is it that the office shall advocate for wellness and resilience through trauma-informed care and only through trauma-informed care?
And through practices that build wellness and resilience. So the research will include different types of studies that have been done looking at resilience. One of the largest resilience studies is the Kauai longitudinal study on resilience from 30 years that's been happening. It's the longest in the country from Kauai, which is amazing. So they are looking at resilience and health resilience and as it impacts over a period of time. But the federal agencies are looking at trauma-informed care principles and practices that are informing what that approach looks like to resilience.
So the office will be seeking to advance wellness and resilience through
the mechanisms of trauma-informed care.
And
yes.
Other
yes.
mechanisms.
Correct. There's different frames and models currently being adopted by different states to build resilience, to look at wellness and how that's defined. So the work of the task force, the task force is currently engaging in that work, doing a huge literature review on what those terms look like, and it will be going into the recommendations report.
I think that maybe the duties, the responsibilities of this office and this advisory board might be better defined. Because reading this, I get the impression that this will be entirely focused on trauma-informed care, not other practices related.
I think broadly defining trauma and what it means to address trauma and address traumatic events and experiences, I mean, kind of touches everything that we've seen, right? We've seen that traumatic experience kind of impacts the way in which people behave, and the impacts of COVID-19 has definitely expanded that in people's everyday lives. So it's broadly looking at the impacts of trauma and how we utilize the principles of trauma to better build resiliency efforts. So I don't know if I'm explaining that very well. I apologize.
No. If your goal is not well stated, you don't have much of a goal. I mean,
do you mean of the task force or of the office?
I'm reading from the advisory board.
The advisory board.
Of the bill.
So the goal of the task force, which is going to turn into the advisory board, that was proposed to turn into the advisory board, what is the goal of that? Is to broadly advise the office on how trauma-informed care practices and the framework is being implemented throughout the state. So it's kind of being, in our thoughts, it's utilized as a body of agencies and stakeholders, system partners, to collectively bring together on a regular basis to get feedback on how pieces are being implemented and work very closely together with the departments and the system partners to inform the way in which the office is operating. So I'm hoping that it will be, and it has been for the last year and a half, that it will continue to be a very active participation from the community and the departments on how we as a state address and mitigate the impacts of trauma. And that is very broad. And so there are very specific things that the office is tasked to do through statute, including creating a social determinants of health dashboard. So as we go through that process as an office, I'm hoping that the advisory board will be able to continue to collaborate and coordinate what that looks like so that the buy-in continues on an ongoing basis on how this is being done. The office is also looking at developing policy on how trauma is being addressed throughout the departments. And I wouldn't want to be creating policy without an ongoing conversation with the departments and getting feedback on whether or not the policy and the practices would be implementable and operationalized. So that coordination and close partnership with these agencies is what I hope to be done on a monthly basis with those system partners. And that's kind of the thought behind it. Am I missing anything?
Well, maybe you should look at page 11, line 2. And I think what you're trying to say is that you're supposed to create a statewide framework for trauma-informed and other responsive practices.
Trauma-informed and responsive practices, yes.
No, and other responsive practices. Because it seems that what you're trying to do is not restrict yourself just to as of yet undefined term of trauma-informed care.
Are you proposing to add the word other to line 2? Okay.
That's what I think you're saying. I'm not sure what you're saying. Anyway, thank you.
Okay.
Okay, thank you. Any further questions, members? Okay, Tia, Director, thank you very much. Okay, I think, so that's the last bill on the agenda. Members, we're gonna recess for decision making. We're gonna come back at 11:30 a.m. in this room for decision making. Okay, at this point, recess. Good morning, aloha. We're at the state capitol. Going to decision-making on our 9 a.m. agenda. First bill on the hearing notice, Senate Bill 1351, Senate Draft 2. Members, recommendation passed with a House Draft 1. Tech amendments. Technical amendments. Bill already has a defective date. We're going to keep that defective date, and it already has blank appropriation amount, so we're fine with that. In addition to that, I'm going to place in the committee report the thoughts of the governor's office. This is a priority bill for the governor. They provided words regarding CDC concerns with ACEs, adverse childhood experiences, and how this bill is needed. I want to make sure we have that, the governor's words, in the committee report. Also, committee report, I want to put the judiciary's words in their last paragraph talking about child abuse and that they have an excellent program, 0 to 3 specialty court. And they also explain why it's needed, working on early childhood mental health. I think that's very important. So that's my recommendation. Members, questions or concerns? Okay, if not, Madam Vice Chair, can you please take the vote?
Voting on SB 1351 SD2, Chair's recommendation is to pass with amendments. Chair and Vice Chair both voting aye. Representative Bellotti.
Aye.
Representative Iligan.
Aye.
Representative Kobayashi.
Aye.
Representative Takenuchi.
Aye.
Representative Nishimoto is excused. Representative Garcia.
Aye.
Thank you, Chair. Your measure is adopted.
Thank you.
Same measure, Health Committee recommendation with HD1.
Health Committee voting on SB 1351 SD2. Chair's recommendation is passed with amendments. Chair and Vice Chair vote aye. Representative Amato.
Aye.
Representative Iligan.
Aye.
Representative Kobayashi.
Aye.
Representative Mizuno.
Aye.
Representative Nishimoto is excused. Representative Garcia.
Aye.
Thank you. Chair, recommendation is adopted.
Thank you.
Thank you very much, members. Next bill on the agenda for this joint hearing, Senate Bill 404, Senate Draft 2 recommendation passed with a House Draft 1. Tech amendments. The bill already has a defective date as well as a blank appropriation. Members, we're going to adopt the amendments by HMSO, their recommended amendments, delete sections 2 and 3, as well as any other amendments by HMSO. Furthermore, we'd like to adopt the amendments recommended by Healthcare Association of Hawaii, HAH. Recommended amendment, page 11, line 15. Let's use no less than, that quote, these three words, no less than, rather than the current language in the bill, at least. This is in regard to the use of 90% of the revenue generated to secure federal matching Medicaid funds. And finally, in the committee report, I want to make sure we let the other committees know no state general funds are used for this program. Very important bill, very important program. No state general funds are used for this program. Members, questions, concerns? If not, Madam Vice Chair, can you take the vote?
Voting on SB 404 SD2, Chair's recommendation is to pass with amendments, noting the excused absence of Representative Nishimoto. Chair and Vice Chair both voting aye. Are any members voting no? Any members with reservations? Thank you, Chair. Your measure is adopted.
Thank you.
Okay. Senate Bill,
No.
no,
Same recommendation.
same recommendation, Health Committee.
Health Committee voting on SB 404 SD2. Chair's recommendation is passed with amendments, noting the excused absence of Representative Nishimoto, who will be noted as excused for the rest of the bills on this vote. Are there any reservations or noes? Seeing none, Chair, recommendation is adopted.
Thank you, members. We're going to move on to the next bill on the agenda. It's Senate Bill 397, Senate Draft 2. Members, we have a companion bill. That was House Bill 1367, House Draft 1. We're going to insert House Bill 1367, House Draft 1, in the Senate Bill 397, Senate Draft 2. Please note that the House bill already has a defective date and blank appropriation. In the committee report, we wanted to make sure that our next committee, the Finance Committee, knows that, or at least to consider the appropriation of $30 million in state general funds, which will draw down approximately $43 million in federal Medicaid matching funds. And that's it. Members, any questions, concerns, comments? Seeing none, Madam Vice Chair, can you take the vote?
Voting on SB 397 SD2, Chair's recommendation is to pass with amendments. Any members voting no or with reservations? Seeing none, thank you, Chair. Your measure is adopted.
Thank you.
Same recommendation for Health Committee.
Voting on SB 397 SD2. Chair's recommendation is passed with amendments. Any reservations or noes? Seeing none, Chair, recommendations adopted.
Thank you. Next bill, Senate Bill 1470, Senate Draft 2. Working with my co-chair, Della Bellotti, I'm going to turn it over for the amendments.
Okay, after much discussion, members, Chair's recommendation is to change this to HD1, where we will direct the Department of Human Services, the Department of Education, and the Department of Health to research rules, policies, and plan amendments necessary to ensure that the state Medicaid EPSDT benefit of the state's Medicaid plan, the state educational services and programs, and the Medicaid Section 19C HCB waiver for individuals with IDD covers medically necessary services, including applied behavior analysis services for individuals aged 26 and under with neurodevelopmental disorders, including autism spectrum disorder and FASD. Going to strike Section 2. We'll leave in the appropriation section, but only for fiscal year 2023 to 2024 for the purposes of the research work that is going to be required. Changing the effective date to July 1, 3000, and any tech amendments identified by HMSO. The reason for this, members, is after much discussion and understanding the various programs that cover this area, and also to constrain and best work with the systems that we have. It's all of these three programs under DHS, DOE, and DOH that relate to this population, the 26 and under population, where we really address that gap group that exists as they transition into adulthood. That's why we're making these amendments. Members, any comments, questions, or concerns? Seeing none, Vice Chair for the vote. Vice Chair of Human Services for the vote.
Voting on SB 1473 SD2, Joint Chair recommendation is to pass with amendments. Any reservations or noes? Seeing none, chairs, your recommendation is adopted on the Human Services side anyway.
For the Health Committee.
Yeah. Health Committee, voting on SB 1473 SD2, Chair's recommendation is passed with amendments. Any reservations or noes? Chair recommendations adopted.
Thank you, members. Last bill on the agenda, Senate Bill 894, Senate Draft 2. Recommendation passed with the House Draft 1. Tech amendments bill already has a defective date and blank appropriation. We're going to adopt the amendments recommended by HMSO, and we're going to adopt in part some of the recommendations by the Department of Health by changing the advisory board to an advocacy board. We're going to put in the committee report, we need clarification from both Department of Health and Department of Human Services. They wanted us to adopt sooner rather than later the transition of the Trauma-Informed Care Task Force to an advisory advocacy board. I'm sorry. We just have not defined sooner, and we talked to the representatives here from the departments. They didn't know what sooner was too. So we need to put that in the committee report. We need a time certain, a date certain by the advocates and the departments on this one. Furthermore, I wanted to give prior concurrence to the Finance Committee to make any necessary amendments. Want to make it clear that Finance Chair does not need to talk to us if it's okay with you to give them prior concurrence. Finally, in the committee report, we want to have Department of Human Services as well as Department of Health and the Office of Wellness Resilience to work with stakeholders, to finalize the language in this bill. They need to do a better job making the language of the bill airtight, and at this point it has not been a perfect bill. If they can do that before Finance hearing, if Finance should hear the bill, we'd ask that they share the recommendations to the Finance Committee. And that's about it. Chair, did I leave anything out? Okay, that's the recommendation, passed with amendments. Madam Vice Chair, can you, if there's no questions or comments, Madam Vice Chair, can you please take the vote?
Voting on SB 894 SD2, Chair's recommendation is to pass with amendments. Any noes or reservations? Seeing none, thank you, Chair. Your measure is adopted.
Thank you.
Same recommendation for Health Committee.
Health Committee voting on SB 894 SD2, Chair's recommendation is passed with amendments. Any reservations or noes? Seeing none, Chair recommendations adopted.
Thank you, members. We're now adjourned.
Good job.